Thank you. So I've been given the opportunity today to speak about a disease that's very important to me, age-related macular degeneration. And what I'd like to do is just to provide a bit more understanding of this disease. So hopefully my talk is not too simple. I know a lot of people know a tremendous amount about the disease, but I really just want to go through some of the basic concepts in age-related macular degeneration. What I'd like to do is just first talk about the eye as an optical system so that we understand some of the basic anatomy that's involved. Then I'm going to talk about the different types of macular degeneration and how the disease manifests itself. And I'm going to talk about some of the treatment options. So I wanted to start off by this disease, macular degeneration. What is it? Macular degeneration is known by several different terms. So AMD, age-related macular degeneration. RMD, when some people put the related in there. Age-related maculopathy. It used to be called senile macular degeneration. Some clinicians call it hardening of the arteries because there is an ischemic or lack of blood supply. That's one of the main pathologies of the condition. And it's also known as congenital disciform degeneration. So it's got several names out there. But we remember that AMD remains the leading cause of blindness in Canada today. It affects people that are over the age of 55, so their age-related condition. It has sort of a minimum age requirement to get the diagnosis. And it is a very common condition here in Western or developed societies. As a result, it has a huge social and economic impact for our society today. Our population is aging. People are living longer. Active, full, healthy lives. And so this disease, being very common, is really having an impact in our society today. If you think about the eye as a camera, you can really understand the disease. So that's how I explain it to people who are newly diagnosed. The human eye is like a camera that takes a picture. So the human eye, like the camera, has a way of regulating how much light gets in there. In the camera, it's the diaphragm. In our eye, that's the iris, which regulates how much light gets in. The camera has a lens to focus the light onto the back of the camera, the film. Our human eye has a lens as well, which focuses the light, but not onto the film, onto the retina. So I explained that the retina acts like the film in the camera. The problem is, now that my younger patients are coming in, no cameras have films anymore. They're all digital, so my analogy is becoming somewhat dated, but I still like to use it. So the retina is like the film in the camera. So you need a good film in order to develop nice images. The macula itself is the center of the film. So where all the light is focused, it's focused into that area, the macula, the very center of the back of the eye. And the macula is what gives us our fine visual acuity. So our ability to read, to recognize faces, to see detail. And the rest of the retina is primarily involved in our peripheral vision, movement, sense of motion, things like that in our periphery. The macula also has the photoreceptors that are responsible for color vision. So it's the area in our eye that's responsible for seeing color. Okay, so that's a brief introduction to some of the anatomy there. Without a good retina, you therefore have distorted image. People often say, I can't see well, doctor, can't I just get better glasses? They just want a better pair of glasses. And I remind them that that's like saying, my camera is not working, the film at the back of my camera is not working, can't I put a new lens or a better lens on my camera and see better? And of course, no matter what lens you put on the camera, if the film is not good, you won't have a clear image. And that's the same with our eye. So if our retina is not working, no matter what glasses we put on in front of that eye or what lens we put in that eye, we're not going to be able to have good visual acuity. So the goal of the eye is to have focusing elements, the lens, the cornea, to put the image in focus on the macula, specifically in focus on the macula, the center of the retina. So when we look inside the human eye, so during my examinations, I take an instrument that allows me to look inside the eye, and we see the optic nerve, the structure that connects the eye to the brain. We see blood vessels that come out from the optic nerve and nourish the retina. And that area within those blood vessels, it's almost defined by the circle of the curving blood vessels that come out of the optic nerve. That defines the macula, and that's the area that I focus in on any of my examinations. The macula itself contains certain special layers. So it has the rods and cones. Those are the light-sensing cells within the retina. Underneath that, it has what's known as the retinal pigment epithelium. And this is the structure that supports and nourishes the vital rod and cone cells. Underneath that, it has the choroid. The choroid is like the blood, one of the important blood supplies to the eye, and it lies underneath the retinal pigment epithelium. Now, as part of normal aging, there are changes that occur to the retina and specifically to the macula. It is a normal process as we age for us to lose some of the photoreceptors. So there's a natural, normal decrease in photoreceptor density in the center of the macula with age. With age, the retinal pigment epithelium undergoes some changes. It involutes slightly, and so we have a less dense pigment epithelium at the back of our eye as a normal consequence of aging. And finally, the choroid, the blood supply that's underneath the retina, also loses some of its fine or little blood vessels, and those are normal parts of aging. But what we see when we have actual degeneration or macular degeneration at the back of the eye. So the hallmark change of macular degeneration is the formation of these little dots that we call drusen. Drusen, I explain to people, they're like gray little deposits, and it's like your hair turning gray. It's your retina's response to aging, but it's a slightly more pronounced response. You get these little fine gray dots that appear at the back of the eye. They occur in the inner layer, just around the choriocapillaris at Brooks membrane. And if we scan them under a microscope, they're electron-dense vesicles of phospholipid, basically the byproducts of metabolism that accumulate as these little round spheres in the macula, the center of the back of the eye. These are called drusen. We usually subdivide them into two categories, hard drusen and soft drusen. Hard drusen are small and well-defined. You look into an eye and you can count 8 of them. So they're very discrete and separated. And they actually are common, and they have a good prognosis. Soft drusen are more damaging and more destructive. So in this case, their drusen are called soft because they're rather amorphous. They start to blend together. They look like sort of ill-defined blobs, and one sort of touches the next one, which touches the next one, and they start to almost congregate together. That's what we call soft drusen. And they have a worse prognosis in terms of vision, so people with soft drusen tend not to see as well and are at higher risk for the more damaging and destructive form of macular degeneration, wet macular degeneration. And they're difficult to count. When we look in and see somebody with soft drusen, it's hard to say that they have 5 or 6 or 7 of them because they sort of all stick together, and it's hard to define where one stops and the next one starts. So sometimes we call them confluent drusen, drusen that are just sort of getting together. So they're qualified by size. Drusen are small, sort of less than 64 microns, and we have a good reference at the back of the eye. We look at the small blood vessels. We can see if the drusen are bigger and small or smaller than the blood vessels themselves, and that allows us to quantify them as large or small drusen. The other change that we see in early signs of macular degeneration is pigment clumping. So the retinal pigment epithelium, that structure that supports and nourishes the retina, will start to get together, and it'll clump into areas where there's an intense amount of pigment, and often surrounding that there'll be areas of less pigment or hypopigmentation. So these pigment clumps are signs of the macular degenerative process continuing to develop in the back of the eye. Another manifestation that we see at the back of the eye in macular degeneration is what we call a pigment epithelial detachment, or a PED. Now, a PED, I explained it's like a blister at the back of the eye. So it starts to be a little dome that elevates, just like a blister would on your skin, in the center of the macula. This is not the destructive wet form of macular degeneration yet. It probably represents more drusen that get together and elevate that area in this localized detachment. So nothing's leaking out of it, there's no blood with it, but we call it a pigment epithelial detachment. And I say to patients, it starts to cover the gray zone between true dry macular degeneration and the more destructive wet macular degeneration. So I've mentioned those two terms, dry and wet macular degeneration. Dry macular degeneration, of course, is the far more common form of the disease. 10% of our population over the age of 55 has dry macular degeneration. So when we talk about degeneration, we always remember the rule of tens. So 1 in 10 people over the age of 55 have it, but 9 out of 10 of those people, the disease stays dry, thankfully. And 9 out of 10 people with dry macular degeneration actually see well. So about 10%, or 1 out of 10 people with macular degeneration have the other form of the disease, the wet form, which is the more damaging and destructive form, as you saw on that video. So the dry form represents only those degenerative changes, the accumulation of drusen, the pigment clumping, the pigment atrophy, and maybe a little blister or a dome or a pigment epithelial detachment. The wet form of the disease, so 1/10 is common, but the wet form of the disease starts to, that form implies that there's now abnormal blood vessels that grow up through that damaged area of the retina between the drusen, and those abnormal blood vessels start to infiltrate the retina itself. And these are abnormal blood vessels, so they lack a good, they're not competent, we say. They leak. They lack a good wall. And so they leak blood, fluid, and hemorrhage. They start to bleed, and bits of our serum leak into the retina. And of course, once that happens, then the retina becomes swollen, there's blood there, and you really don't see well. And the vision tends to go down very rapidly with wet macular degeneration. So again, that represents only 10% of macular degeneration, but it accounts for 90% of the blindness due to macular degeneration. Again, it's very simple to apply that rule of 10. So AMD, cause of severe visual loss, about 10% are blind because of dry, about 90% are blind because of wet if you have severe visual loss. In the dry people, the people with dry macular degeneration that are blind, it's usually because of the coalescence of those areas of pigment atrophy, and they start to get larger and larger and larger. And we call that geographic degeneration. It just means the atrophic areas all stick together and look a bit like a map. So it almost looks like the map of Canada or the map of North America as these areas coalesce together, and you see this large cutout map-like region at the back of the eye, which we call geographic atrophy. And for people who are blind due to dry degeneration, they have extensive geographic atrophy. So, the wet degeneration, how do we tell the difference between wet and dry? When we look in the eye, we look for the hallmark signs of wet. We look for the fluid, thickness, we look for the blood, and we look for lipid or fat. These are called hard exudates that leak out from the blood vessels and accumulate in the retina at the back of the eye. The end stage of macular degeneration, so if you progressed from dry to wet, and then from wet to what we call the end stage, that is what we call a disciform scar. So after those blood vessels have grown into the back of the eye, they've bled, leaked, hemorrhaged, they undergo usually a scarring reaction. Our body tries to sort of wall off that abnormal area. And you do see this big round scar. Looks like a disc of scar at the back of the eye, so we call it disciform degeneration. And that's the end stage of macular degeneration. Once you have that disciform scar, your degeneration usually does not progress anymore. The scar walls off any further changes. But of course it means the retina is damaged to the point where it doesn't work in that area at all. And that's an area right now for which we do not have any good treatment. So once a person's degeneration has advanced to that level, we usually only are able to offer them visual aids and things like that, but we cannot offer them any further therapeutic intervention at this time. So how do we tell the difference between wet and dry? Of course, it's very important to understand prognosis. People with dry most often do well. People with wet, they will not do well unless we employ a treatment. It's very important to decide which treatment to use. So if you're dry, we tend to give you vitamins. If you're wet, you tend to get injections of medicines into your eye. So how do we tell the difference? The gold standard test, other than the clinical exam, which gives us an indication in many cases, is what's known as the fluorescein angiogram. So fluorescein angiography is a test that we apply every day in our clinics. We basically take a dye, like a carrot juice, and we inject it into one of the veins in your arm or your hand. And this carrot juice dye then travels to the eye and will highlight any areas of abnormal blood vessel formation. So abnormal blood vessels light up like a Christmas tree once this dye is injected into the patient's eye. We use a high-speed camera that captures the dye as it's flowing through the eye, and then we look at the images. And that's the gold standard to tell dry from wet. The two diseases appeared very different on the angiogram, and we can identify areas of atrophy, geographic atrophy in the dry, and they stand out in very stark contrast to the abnormal blood vessels of wet macular degeneration. When we have wet macular degeneration, we can also subdivide it into two categories. So the wet type can be subdivided on the angiogram into what's known as classic or occult. Now, most macular degeneration is actually occult, not classic. So if you hear, oh, you've got classic wet macular degeneration, it's not that you're a typical example of the disease or something like that. It's just a term that we've coined in order to describe a membrane that is small and very well defined. We can take a pen and just trace out exactly the borders of the choroidal neovascular membrane, the abnormal blood vessels that have leaked, grown into the retina. So on the classic form, it's very well defined. They tend to be smaller. And this was a very important distinction, especially when we had our older treatment versions. The classic form of the disease actually responded better to some of our early therapeutic interventions. The occult form, it's like the difference between hard drusen and soft drusen. The classic form is like the hard drusen, small, well-defined. The occult is like the soft drusen, sort of amorphous. And it's hard to find the border of it because it seems to be leaking from here, 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 and there's little bridges between them where it's still leaking on the angiogram. So it's a more lacy, ill-defined network of blood vessels underneath the retina. In our initial treatments, this was very much more difficult to treat. If you can imagine you're using a laser and you want to focus a laser on one specific point, well, if you have a classic lesion, you could zap right on that lesion and destroy it. But if you had the occult form, it was more difficult to know where to target your therapy. So the classic and occult are two terms that are used to subdivide the wet form of macular degeneration. Now, if you have macular degeneration, what are your risk factors for losing vision? So how do we know or how do we predict somebody who's at higher risk? Well, the first most important factor is age. So as you age, the retina undergoes further degenerative changes. Even normal changes of loss of the photoreceptors put you at higher risk. So as your age increases, that's the number one risk factor for developing more extensive macular degeneration. Hyperopia, or being farsighted, is also quoted as a risk factor. So those of us, like myself, who are nearsighted are slightly protected versus a farsighted individual. Family history is extremely important for predicting vision loss due to macular degeneration. So if there are other members of your family who have macular degeneration and who have lost vision due to it, that does place you at higher risk. Having the soft drusen also puts you at higher risk for vision loss, as well as extensive pigment clumping. But the single most important risk factor, which outweighs all of those, is actually smoking. So the biggest intervention that we could do in helping people to maintain healthy eyes as they age is to encourage smoking cessation. That overwhelms actually the other risk factors. And it's something that many people who are smoking they don't want to hear that. They find they'd rather have a pill or something else that they can do in order to protect their retina. And it can be a very difficult habit to break. But smoking is the single biggest risk factor that we're aware of for conversion to wet macular degeneration that is easily modifiable if we could only get people to stop smoking. Sadly, I think actually some of our youth are actually picking it up more now. If I ever go and pick up my wife from after school at Rideau High School. I can't believe how many people are out there smoking as younger people, more than I remember from years ago when I was in high school. So it's a message that it's really important for me to get out, that we really want to protect our eyes by smoking cessation. So I've talked about the two diseases, the wet, the dry, how we subdivide it. What about the treatments? Well, the treatments of dry macular degeneration, it's an interesting story. I'll talk more about it when I do the talk on nutrition. But primarily, it's directed towards ocular vitamin supplementation. And this came to us through what was called the AREDS, or the Age-Related Eye Disease Study. Interestingly, that study was actually put forth and done to disprove the fact that vitamins would be beneficial. Because at the time, people were really pushing vitamins on patients, spend more money, buy vitamins, spend more money. And many of us in the who were practicing ophthalmologists thought that this was something that was a bit hokey-pokey, and we didn't want our patients to waste money on something that wasn't really going to be helping them. We thought as long as you didn't smoke, had a good balanced diet, kept your blood pressure under control, was the best thing you could do. So that study was initially put together in order to disprove the fact that spending extra money on vitamins would help your eyes. What it did, though, was actually kind of surprising. Over 10 years, if you took the vitamins recommended by the study, your rate of severe visual loss was reduced by 25%. So it was actually a significant treatment benefit. It only was applicable to people who had significant macular degeneration to start with. So if you had no or little macular degeneration, your rate of visual loss was so low that it was difficult over 10 years to detect a treatment benefit by taking the vitamins. Excuse me. But if you had more advanced disease, then you could definitely see a divergence, an increased rate of progression if you were on the placebo or not getting the vitamins, and a lower rate of progression if you were receiving the vitamins. And again, over 7 years, that was about a 25% reduction. So the ARED studies told us that vitamins can be helpful for dry, that you have to be careful with some of the formulations that were initially put out there. For example, the beta-carotene constituents of some of the AREDS 1 formulation did increase the risk of lung cancer in smokers. And remember, smoking was the biggest risk factor for AMD to begin with. So you had a lot of people who were smokers who had the disease, so they had to be careful. And since that study, we've had more research to look at the benefit of other ocular vitamins, such as lutein, zeaxanthin, omega-3 fatty acids, that we'll talk about in the nutrition talk. The one thing that's important for me to mention is that, are these vitamins safe? That's always been asked for me. And the answer is overwhelmingly yes. You have decreased mortality and morbidity when you're taking these vitamins, so they are safe for you. People actually live longer on them. So I wanted to speak a little bit about some of the historic treatments for wet macular degeneration before we open it up for questions. Historically, the first treatments that were out there were laser and photodynamic therapy. The laser was to go in and zap and destroy the abnormal blood vessels, but of course in so doing, it zapped and destroyed the retina that was around the abnormal blood vessels as well. So it halted the progression of the disease, but it permanently etched that scar where the blood vessels were. So it was, in effect, as bad as the disease. It sort of froze your eye at your current status right there, but it didn't let it progress. Then we developed photodynamic therapy, which was an attempt to use a cooling laser, a less powerful laser, in order to target the blood vessels but protect the overlying retina. The problem with PDT or photodynamic therapy was you treated the blood vessels, they went away, but they didn't really all go away. So then they started to grow again. So then you had to treat them again, and then they grew again. And so you had to repeat the treatment every 3 months. The every 3 months comes from the fact that in the United States, you could only bill for a treatment once every 3 months, so you couldn't repeat it more often than that, so that became the standard. But as these blood vessels came and went, there was progressive loss of vision. Then we started to develop intraocular injections. And that'll really be something I'll dive into in my talk this afternoon on modern therapy. But of course, that's produced a landmark breakthrough in macular degeneration. It really helped us to treat this wet form of the disease. There are a few other historical treatments that are worth mentioning. Transpupillary thermal therapy, another form of laser therapy, a cooling laser therapy that you didn't have to get an injection for like you did in PDT. Again, the papers have shown it doesn't work. Feeder vessel ablation, where you went in with a very tiny laser in order to target the main blood vessel that was causing the wet macular degeneration. Again, in long-term studies didn't help. Laser for drusen. We could use a laser to zap and destroy drusen at the back of the eye. We could make drusen disappear, but it didn't change the course of the disease. It didn't affect your probability of developing wet macular degeneration or vision loss from geographic atrophy, so we've stopped doing that. And one exciting breakthrough that was really exciting for a while was translocation of the retina. We'd pick up the retina and move it away from the choroidal neovascular membrane and put it down overlying another part of the choroid. And that was an exciting breakthrough that people tried that for years. But that surgery was associated with many complications for the eye. And the blood vessels did continue to grow at the back of the eye. So that's really been abandoned now as well in favor of our modern treatments. So I will just summarize then. I'm going to skip through all that on the... there we go. And say that macular degeneration is the leading cause of severe vision loss in our world today. It affects people over the age of 55. There are primarily two forms, the dry and the wet form. And differentiating the two is very important in terms of prognosis and treatment. Yeah, so the question is about electronic or e-cigarettes, which one of the ways to try to curb the addiction. And I think anything you can do to get off the cigarette itself, like it contains nicotine and stuff like that, but many toxins within the cigarette itself, which we believe build up at the back of the eye. So any effort that can curb somebody's use of the cigarettes themselves, I think is worthwhile. There's been some suggestion that those cigarettes are popular with the youth, and actually they get hooked on them, and then evolve towards the real cigarettes. So as long as it's used not as a substitute for smoking, but as a way of reducing your cravings and eventually getting you off. So the question, if you couldn't hear, was if you have wet macular degeneration and you receive the laser, would that change now to dry? So you can go from wet to dry with treatment. So if we are able to treat you with the laser, with PDT, or with injection, and we've stopped the leakage, and there's no more bleeding, and there's no more fat or lipid leaving the abnormal blood vessels, then your retina becomes flat again, and on our testing, we don't see any thickening, any swelling, any fluid, then you are now dry again. Yes, definitely. So the question is, once you've stopped receiving the injections, is there a point to resuming them? So Lucentis is now a drug that's covered in Ontario, and people receive it if they're over the age of 65 and have the diagnosis of macular degeneration. You shouldn't have to pay a penny for that. The less expensive alternative medication, Avastin, the cost of that varies, but it's typically around $60 or so per injection. Now, once your clinician decides that you don't need any more injections, that usually indicates that there's no more leakage, no more wet degeneration. So the injections are only able to treat the wet degeneration. The injections that we do with Avastin and Lucentis are unable to cause regression of scar tissue. So because they don't modify scar tissue, if a patient only has scarring in their eyes, I strongly recommend against the injection, because the injection would not be predicted to have any benefit to you. If there's no fluid, if there's no blood, then it's not going to have any benefit. And it only exposes you to this small, very small, but there are some small risks associated with an injection. So once the clinician has decided, okay, you're dried out again, then I don't inject my patients again until I see signs of disease activity.
So I go to my family ophthalmologist once every 4 months. He checks for hemorrhage. Is that the right thing to do?
That's exactly what you need to do. But be mindful also of your symptoms. So the symptoms of wet degeneration are new onset of a scotoma or a blind spot, new onset or worsening distortion in your vision. And if you notice those, don't wait the 4 months to the next appointment.
Yeah.
Get back in earlier so they can take a look.
Okay. And OHIP only doesn't pay the full amount. They only pay so many times a year. I ran into that. I had to go to my insurance company to cover it.
OHIP will pay for it 12 times a year. 12 injections a year.
Not according to my doctor.
Let's be absolutely certain that OHIP pays for Lucentis injection up to every month. Okay, once a month is covered by OHIP. Now, I have heard that, and if you're getting, so there are limited use criteria for Lucentis, so you have to have active disease, you have to have signs of leakage, you have to be over the age of 65, your vision has to meet a certain criteria. So there are criteria for OHIP to pay for it. There are criteria. Sadly, some people may not meet those criteria. So either your vision is not good enough or there's not signs of disease that month, but your clinician still thinks you would benefit from the injection and may still recommend it. Then you have to make a decision if your insurance pays for it. Luckily, if your insurance covers it, we now have a program in Canada called Foresight, which will pay entirely any deductible. So any portion that's not paid by your insurance company can be covered. That's an outstanding program that's been introduced. As well, we have the less expensive alternative, Avastin, which can be considered in some patients, although there's a lot of discussion. It's controversial. We'd have to think of risks and benefits of both of those choices of medicines. Avastin, though, typically would not be covered by insurance, so you'd be liable 100% for the cost of that.
A few years ago, I had a spontaneous rupture of the vitreous. And I still get some leakage from the vitreous, and the way I tell is that I have these bright fluorescent pink spots all over my eye. Is that at the time when it first happened, I wasn't getting injections, but now I am. Is it related to the injections as well, or is it made worse by that?
Okay, so every patient will experience in their life a collapse or an involution. We call it a collapse or detachment of their vitreous gel, where the vitreous gel, which makes up the inside of the eye, if you crack the eye open, it's filled up on the inside with the vitreous gel, much like if you crack an egg open, it's filled up with the yolk. So that's at the inside of the eye, and at one point in our life, it'll collapse down. Okay, and that gives you usually a shower of floaters, a shower of flashing lights inside your eye. That's a normal age-related process that will happen to all of us at one point in our life, a normal process. The age varies at what point it's going to happen based on your myopia and several other factors, but typically it's in our 60s or our 70s. Now, if you are receiving injections or any other intervention in the eye, such as cataract surgery, laser treatment, all of those can speed the posterior vitreous detachment, the collapse of the gel, and it can occur more strikingly in terms of more symptoms and earlier and quicker than it may have without the injections. But for sure, it would have happened anyway. Okay, so it's a normal changing in the eye. It doesn't represent any pathology. One more question at the front.
I had the vision dyeing or photodye injections done many years ago.
Yeah.
I now have scar tissue on my eye. Is there any way of lessening the scar tissue or healing it up a little bit to improve the sight? Any?
Yeah. The scar tissue that forms is personally my biggest frustration in my practice today. So the quick answer to that is, sadly, we do not have at this time a way of removing or treating the scar tissue. That is because the scar tissue is the retina now that has become scarred. So if we peel it or remove it, we're effectively removing the retina. What we need is a way of regrowing the healthy cells where that scar tissue is. So that it leads us to the promise of some of the new research, such as what Dr. Sulfidis was talking about with the stem cell research. But right now, we don't have a way of getting rid of those scars. We need a way of regrowing the healthy tissue. And at this time, we don't have something to offer patients with scar tissue, sadly. We do have other things. Dr. LaPlante will talk about ways of maximizing vision, getting other retinal focus, ways of magnifying things. So there's strategies that can be used. But as far as getting rid of the scar tissue, we don't have that right now.
Could I ask just a quick question as well?
Yeah, so secondhand focus is less dangerous than firsthand, but still has an effect.
It's my time, huh?
Yeah.
Doctor, could you tell me if you have any experience in your research as to which is more successful, treating with the injection or with the scar tissue? And in addition to that, are there any results that indicate that at certain age, when one is treated with scar tissue, is there any improvement in vision?
So unquestionably, our best treatment to date, unquestionably for wet macular degeneration, remains intravitreal injection. So the injections remain our best treatment. There's no age at which we have to stop injecting or anything like that. But the scar tissue remains a large frustration. And irrespective of age, we do not have a good way of intervening with the scar tissue. So thanks everybody for your attention. Wonderful audience. I can tell everybody who's paying attention. Thank you very much for that. And we'll see you again soon.